So this is where we left off last time for those of you that were here. And we were talking about, retained primary teeth, ankylosis, and what you can do about that. And so we mentioned in this case, decoronation was the ideal option. And does anybody remember what happened on one side versus the other? What? Yeah, so when you do the decoronation procedure, the enamel has to be removed, and the cementum dent, any part of the tooth has to be removed 2 millimeters below the alveolar crest so that the alveolar bone can fill in, and you can see something more like you see on the right side here. And in this case, only one side was done correctly, so you can see the bone follow on the one side and not on the other side. Incidentally, does anything else stand out to you on this X-ray here? Yeah, something going on down there, right? So we had to send that out as well, maybe. All right. Sorry, my mouse is. Okay, technical difficulties here. We are not advancing. That is, okay. Well, let's see if it works now. Okay, now we're working. Yeah. So we had, so what might come in mind when you see a radiolucency in the lower anterior mandible like that? What kind of things go through your mind? Or does anything? We're digging back years now. More years for me than you, though. So what's that? Yeah, that would be my best guess too, right? I mean, like, younger patient, lower anteriors, and no symptoms on the, as far as vitality goes at the lower teeth. So most likely some cementoosseous dysplasia. Okay, so let's look at another case, and let's start diagnosing again, and let's start thinking about what we can do to help this patient potentially. Okay, so first off, when you see this presentation, what are some things that stand out to you? What do you notice? Okay, there's a deep bite, right? A little bit, right? So you look here. What would you estimate that overbite is? Like if you had to put a millimeter number to it. Okay, yeah, maybe like 4 or 5 millimeters, so definitely a little bit deep. So now, we all understand what a deep bite is, right? We understand when we say deep bite, we have a picture in our mind of what that is. But a parent doesn't necessarily know what a deep bite is. So when you're talking to a parent about a deep bite, what are some of the things that are going through your mind? And really, with deep bites, there's one thing that I always want you to associate whenever you see a deep bite. What is that thing? What does it mean? What can happen? What often happens? Okay, sometimes palatal impingement. It's so funny that palatal impingement gets so much attention, right? Because it's like on all the board questions and everything like that, and I get it, right? If there is palatal impingement, yes, it can recess the tissues. How many patients, let me ask you this. By raise of hand, how many people here have seen more than 10 patients with palatal impingement that caused a long-term problem? And like nobody, right? So yes, it is a problem. It is something we want to pay attention to. But there's something that's much more common of a problem with deep bites that all of you, almost guaranteed, have seen multiple patients, especially if you're looking. What is that, Austin?
Where are the lower central incisors? So that's kind of hard to see.
Absolutely. So it's definitely hard to see if you don't take a photo that captures it, or if you don't have that as part of your clinical exam, right? So I want you to associate in your mind deep bites with where of the lower anterior incisors. And the reason for that is that when you have a deeper bite, the edges of the central incisors tend to hit right on the cingulum of the maxillary central incisors. And when they do that, you tend to see wearing. And the other thing that makes it a little bit more elusive is that as it wears down, the teeth start to look straighter, right? Because the edges of the teeth look straighter. And so I've had dentist kids, hygienist kids come in, 12, 13 years old with severe wear on the lower anteriors that was undetected because no one was looking. And, when they bite down, you don't see it. So one of the photos we take with all of our patients when they come in is a center open photo, right, to be able to capture the edges of those teeth as well. And so you can actually look at that and make sure that you're able to diagnose that and treat it as needed. So let's just say that the patient needed nothing else and that was the only problem that they have. How might you treat something like that? Any ideas? Okay, yeah, some type of a bite plate. All right, so what type of a bite plate, what kind of options would you throw out there? Are you talking like one fixed like to bands or something, like a bite plate fixed to bands on the molars, or? Yeah, probably. Okay, you could do like a modified type of Nance that like goes up on the teeth. You can do that. You got to be a little bit careful with hygiene, right? Because like if it's covering the teeth, then it could potentially be a food trap, cause some problems there. Okay. What else?
Like the one where you brought it up and kind of align a little bit, and then you would, it's like little hooks on it. You would just tie it to the wire, kind of, and then you kind of move it.
If you have a wire.
Yeah, so you got to bond up first.
Okay.
At least like a little 2x4 or something.
Okay. Well, that would work while they're in treatment, I guess. But I mean, like if this patient is, maybe she's like 9 or something, right? She's got maybe a few years, right? That you need to be aware of this, where that's happening. So I see what you're saying. So you're saying if you go in and correct the deep bite at this age, let's say that you don't want to treat him at this age. Let's say you're not going to treat him orthodontically. You just want to make sure that the wear doesn't get worse. Like what options do you have? What's that? Okay. Okay, you could potentially use a little I like the way you're thinking. You could potentially use a little popsicle stick just to flare the anteriors a little bit, maybe get them out of the way so they don't hitting. We're getting closer to something that's really easy. Any other ideas? A removable type of retainer. Yeah, you can do a Holly, right, with an anterior bite plate. Because what's happening at night in kids that's not happening at night with adults? Yeah, eruption, right? So you have something that's a huge advantage. So if all you do is disclude the posterior teeth during the nighttime when they're sleeping, their teeth are going to erupt in the back. And then during the day, those anteriors, they may be close to hitting, but they're not going to be hitting and wearing down the same way. So you're protecting them at night because the retainer itself, and you can use a Holly retainer, you can use a Thoreau type retainer. We call them like bio-Hollies. It's basically like a 2 millimeter suck down. You can do any of those things to keep them off of their teeth at night. And if you're able to do that in a growing child, you're not going to see the wear progress during the day, at least from normal function. I mean, obviously, if they're biting their nails or something like that, yeah, they could have continued wear. But for normal function, chewing, all those things, they're not going to progress if you keep them off their back teeth at night. Okay, so deep bite. What other problems do you see here? What else are we seeing?
Severe mandibular crowding.
Okay, severe mandibular crowding. Great. So we all know what that means, right? We see that. You say that. It makes sense. All right. So for anybody who wasn't here last week, before I go to the ones who was here last week, what are 3 major things potential outcomes that we associate with crowding that's not addressed? Okay, so what are 3 major things that we associate with crowding that, if you don't do anything about the crowding, these things could happen? All right. Okay, that is one of them. Very good. All right, so one of the things is impacted canines, okay? So we'll look at the panel later to see what type of a risk, and that's more of a risk typically on the maxilla than the mandible, although it can definitely happen with both. More often on the mandible, instead of impaction, you tend to get ectopic eruption, right? You tend to have that mandibular canine go wayward somewhere it's not supposed to go. It may come in. I had a patient come in this week, literally she's 43 years old. She had a lower canine directly in the middle of her lower anteriors. And now it's to the point, the only reason she was there is because it was finally making the permanent incisor behind it loose at 43 years old. So yeah, they go haywire. So impacted teeth, crowding associated with impacted teeth. What are the other 2 things? Do we need to open it up to the people who were here last week? Okay, root resorption. Yes, all right. Yes, we do, of course. Okay, so one of the things is root resorption, right? Going along with ectopic eruption, right? Those permanent teeth can run into roots of other teeth, and you can have root resorption. So you want to check for that. Again, we'll see some of this on the pano when we're looking. And what is the last thing? All right, the last thing that I always want you to associate with crowding. All right, when you're talking to a parent, so they understand what the implications of that are. Yes, loss of permanent teeth, right? If you don't address it earlier, you may have to pull permanent teeth later in order to address that crowding, all right? So those are the 3 things when you see crowding that we want to be talking about, all right? Those are the things you want to be looking for. How likely are each of those to happen? All right, so when we look at this patient, you mentioned severe mandibular crowding. So if you had to put millimeters to that, how many millimeters of crowding would you say and why? What are you looking at to make that determination? No one wants to throw out millimeters? You guys are so quiet now that we're in a big room with so many people. What's that, 6 millimeters? Okay, so all right. So where are you getting that? So like, what are we looking at that we're seeing 6 millimeters of crowding? Say that all again. Okay, so you have blocked out lateral incisors. All right, so let's talk about posterior crowding first. All right, so do we have posterior crowding when looking from the mesial of the canine here to the distal of the molar there? Do we have crowding in that segment? No, right? That's normal, right? Molar, second primary molar, first primary molar, primary canine. Yes, the primary canine is smaller than the permanent canine. The primary first molar is a little bit bigger than the premolar, and the primary second molar is a lot bigger than the premolar, okay? So assuming that we're able to save that space and that E-space, then there's not going to be crowding in the posterior segment. Well, that makes it really easy to determine the number of millimeters of crowding in the anterior segment. So one of the things that you guys mentioned was overlap of the teeth, right? So when we look at the overlap of the teeth, I mean, if you just look at how much these are overlapping, what, probably like 3 millimeters, maybe? And then another one here, so 4 millimeters, another one here, 5, you know, at least maybe 6, okay? So that's the simple way to do it. Now, what's the only other thing that you need to take into consideration when you're measuring the crowding besides the overlap of the teeth? What else do you have to consider? I heard curve of spine and I heard something else. Yeah, proclination, right? So, I mean, those kind of go hand in hand, right? But, you know, if you have a deeper curve of spine, right, that's kind of like you're going to have to level that. It's going to require some space, right? Because those are going to come more forward. And then when the teeth are retroclined, you're going to be able to procline them, all right? And that will give you some more space, right? So every millimeter you procline the teeth, so let's just say they're retroclined to the tune of like 1 or 2 millimeters, well, that's going to give you a little bit more than 1 or 2 millimeters when you procline them, right? So you're going to subtract out any crowding, or you're going to add crowding to your number if they're already proclined and you know you need to upright them, right? Because you're going to need more space to do that. Okay, so that gives you just a rough idea of the crowding. So let's talk about the maxillary teeth then. When we look from the mesial of the canine to the distal of the first molar on the maxilla, do we have any crowding in those segments? No, right? That's pretty good, right? We have all the baby teeth. There's no big deal. You can see it's symmetrical from right to left. You know, you have about maybe a millimeter and a half of spacing in between the centrals. And so would you say that the upper arch is crowded or not crowded? Okay, there's probably not enough space for laterals. So how much space do we need for laterals? And again, we don't know yet because we don't know what the laterals look like. But assuming they're normal size laterals, how much space do you need for the laterals? 6 to 7, yeah. You know, just ballpark it at 6.5, right? So, you know, let's just say you have, what, like maybe 3.5 millimeters there. So let's just say you have 3 millimeters of crowding, and then, you know, probably close to the same there. So you probably have 6 millimeters of crowding minus this middle part. So, you know, you have a millimeter of space there. So, yeah, you know, somewhere between 4.5, 5 millimeters of crowding on the top, okay? All right, what else do you guys see with this case? What else stands out to you? What other diagnoses can you make? Okay, so a little bit more kind of end-on class 2 molar on the right side. Now, do you think that that is a function of the way that the photo was taken, or do you think that that is a true kind of asymmetry, right? So if one side's more class 2 than the other, and why? Okay, what other pieces of information would you see on here that may indicate that it was the photo and not actually, what's that? Yeah, the midlines are on, right? So I mean, like that would be unusual if there was an asymmetry from the right to the left side. Are you missing any teeth on the right versus the left side, or they have the same number, right? You haven't lost an E early, causing like mesial drift, right? Is there anything on the upper that's going on? Like, is the upper more forward on the right side compared to the left? Like, it doesn't appear to be, right? So like, you know, everything else is telling you that it's probably symmetrical right to left except for that photo. So that's, you know, those are the way you kind of want to process that. Now, obviously, if this patient's sitting in your chair, you can just sit down and look at it together, right? And say, okay, well, what is it? Or if you have a cone beam of the patient, you can just turn it from right to left and see what's going on. But again, when you're looking at everything, you want to like try to put the whole picture together. Like, what are the evidences that are showing you one thing, and what are the evidences that are showing the other thing? All right, let's focus more, less on the teeth and more on the face. What are you guys noticing about that? Or go ahead. Okay, she's got some old lady lips. Now, so does she really have old lady lips, or is that a function of maybe the photo? Yeah. Okay, so what are you seeing in that photo that tells you that it may not be 100% accurate? Actually, what are you seeing in both photos, both the profile photo and then also the facial rest photo? What are you noticing? Would you call that a frontal rest photo? Would that be okay? So she's got some muscle activation going on, right? You can kind of see it in the corner of her lips. You can see that she's kind of like smirking a little bit. and the same kind of thing on the right side here. So, you can't really accurately say like this is where things are, right? So this is, in a sense, less diagnostic, so we're going to need more information to figure out what's going on there, okay? Any other things, like what do you notice about the smile? Would you say that like the smile is ideal? Would you say that, that there's things, let's put aside this, the spacing or crowding issues or whatnot, just looking at the smile as a whole, like, do you like what you're seeing? Would there be things that you would like to see that would be different? Like what would you, if you could just change something about the smile, would there be anything you would change? Okay, you could have some more gingival display, because right now on her full smile, is she showing much of the gingiva? No, not really a lot, right? So how much gingiva would be ideal? Yeah, at least a millimeter, maybe 2 millimeters. And why? Because, some people would say, well, 2 millimeters of gums, that's kind of excessive, but what factors into that equation when you think about how much gums somebody should show? Okay, she's a girl, right? So females tend to tolerate / look better with a little bit more gingival display. That I would agree with that. What else? Exactly, right? So as you age, you're going to show how much less per period of time? And when does that typically start? Ish, yeah, exactly. It's about 1 millimeter per decade, and typically around your 30s, you're going to start noticing that. So 30 to 40, 40 to 50, and so on, right? So being a younger patient, we want to make sure she has at least some adequate gingival display, at this age, so that she can age well, right? So let's look at our pano now. So what do we see on our pano that we're concerned about? We mentioned on the lower, we had about 6 millimeters or severe crowding is what it was mentioned. All right, so looking at the lower dentition, is there anything about the crowding that is so the three things that we mentioned about the crowding, right? Root resorption, impaction, and potentially permanent tooth extraction later. Do you think that any of those things are in her future? Okay, potentially canine impaction. Why do you say that? Oh, on the maxillary. Okay, yeah. Well, we'll get to the maxillary. I want to stick with the mandible just for a minute here. So on the mandible, do we think there's going to be any of those? What is the chances of any of those three major problems we talked about? Root resorption, impaction, or permanent tooth extraction later? Like looking at the mandible alone. What's that?
The lower right 5 is absent. So
okay.
We're not going to gain that E space really.
Okay. So if we keep the lower right E, well, now we all of a sudden have more crowding than we did before, right? And so, that's going to be a treatment planning decision that we're going to have to make, right? But we'll set that aside for now, all right? So what else? Let me just start, mandibular impacted canines. Is this a high probability in this case? All right, and why not? Like, what are you seeing that's telling you that it's not super probable? Yeah, they're pretty straight up, all right? The tip of the canine is right in line with the root of the primary canine here. They're not crossing over to the laterals. They're pretty much erupting in the right space, right? Yes, there's crowding in the lower anterior that's going to need to be addressed. But yeah, not like a huge red flag as far as the mandibular canines go. So let's go ahead and talk about the maxilla now. All right, so looking at the laterals that are coming in, you guys already properly identified that we're not going to have enough space for the lateral incisors. So now let's look at the canines. So what are you seeing with the canines? What's the chances of these impacting or not? It was mentioned that the maxillary right canine, that the apex of the lateral root is relatively close to the tip of the maxillary right canine. And I would agree, it's closer on the right side than it is on the left, and it's also a little bit higher up on the right side than it is on the left. If you had to guess at this point where these canines were going to erupt, would you guess that they would erupt more facially or more palatally? Facially, and why? Okay, so yeah, two things. One, they do appear smaller. The left side appears a little bit larger compared to the right side, so maybe between the two, the left side might be a little bit more palatal than the right side due to the magnification. And for those of you who haven't been with us before, and if you didn't know that, so on a pano, right, the things that are closest to the sensor are going to appear the most magnified, right? And so when we look at a pano, if you see a tooth that looks abnormally large, it's probably not likely that it really is just one tooth that's abnormally large, right? That's not a common thing that happens, although it can. It's probably more likely that it's magnified due to being a little bit closer to the sensor, all right? And then what's the other radiographic piece of information that tells you that these may be a little bit more likely to be erupting facially than palatal? Yeah, the angulation. And these are angulated more in what orientation, would you say? Yeah, they're more vertical, right? So they're less horizontal, all right? So, and this can change, right? So this can, obviously these can move and this can change. But at this point, it seems like, okay, well, these are maybe in the middle of the bone, or if not, maybe a little bit facial, okay? Now, let's talk about the maxilla. We mentioned the possibility of root resorption and the possibility of impaction. So if we do nothing in the maxilla, what do you think is going to happen? So we mentioned that if you had to put a percentage like on impaction, right? I mean, this is just totally a guess, but you have to make this determination in your mind every patient you treat, right? Because it's really a numbers game, a probability thing. If there's a 1% chance that something's going to happen, and it's a 2-year treatment to prevent that 1% chance, and you can fix it just as well later, well, you're probably not going to recommend treatment for that, right? But if it's like a 70% chance something bad's going to happen, you're probably going to recommend treatment, right? So if you had to look at these canines and say, like, what's the percentage of chance that these are going to become impacted, like, what would you guess? Let's just go with we'll go with a vote, all right? So who would guess like more than 50% likely to become impacted? All right, so everybody's going to say less than 50%? What's that? Okay, so this is a borderline case, all right? I would agree. This is a pretty borderline case. I mean, there seems to be room. There's not a lot of signs that they're going to impact. There's not a lot of signs that they're going to have root resorption. And so what about permanent tooth extraction? Who sees permanent tooth extraction as being necessary in the future if we don't treat now? Okay, maybe. Got it like halfway. All right, possibly, right? And that's also going to depend on what your phase 2 treatment goals are, right? If you're comfortable with flaring the anterior teeth and creating space that way in a slightly undersized jaw, then yes, you can probably get all these teeth in without extracting, right? If you are of the camp that you would rather have the teeth upright in the bone, well, then you're in a different situation. You're probably either going to need to expand or do a lot of IPR or create room some other way in order to accomplish that. So, and there's, phenomenal orthodontists across the country, and they would you would have some that would pick both. You'd say, no way I would expand on this kid, and others would be like, wow, like I would never not expand on this kid. Now, the pediatric dental residents know I'm kind of an expandodontist, right? I tend to expand, and I try to make jaws as good as possible when there's a jaw size discrepancy, because it just makes sense in my mind, right? If there is a jaw size discrepancy, the ideal thing would be to correct the jaw size discrepancy, right? For me, I'm like, okay, well, get the bones right when you can. You can't really get the bones right later, or you certainly can't get them right later as easily as you can when they're younger. But again, that's the way that I see things, and not everybody sees them that way. So let's look at our Ceph now. What is our Ceph telling us when you look at this, besides the fact that you can't really see the soft tissue well, and besides the fact that it looks like she was kind of pursing her lips in the Ceph as well? What are you noticing about the Ceph? What are some of the findings that you can see that stand out to you? Okay, so the incisors are upright, so they're not proclined right now, right? That gives us a little bit of wiggle room to deal with the crowding, right? I would say they're too upright. How upright should they be? What, if you look at the ideal aesthetic standpoint, how do you tell if they're too upright from purely aesthetic? Now, I mean, let's put the Ceph measurements aside because we don't even have them up there. But pure aesthetically, how upright or flared should the central incisors be? What's the ideal? Okay, so relative to, okay, so you draw a line and it lines up behind the orbit here. So let's talk about the facial surface of the central incisors, because that's what people see when you smile, right? So how should that facial surface look? Because roots are different too. Sometimes roots come out at an angle or up or left or right. So let's talk about the facial surface of the central incisor, because that's what people see. All right? What's ideal? Where should that be ideally within the smile? Like, what angulation should it be ideally? Should it be slanted forward? Should it be slanted back? Or should it be, what's that?
90 degrees.
Yeah, pretty much 90 degrees, right? I mean, like, that's like, the general consensus is that, when you look at really nice smiles, the facial surface of the central incisor is going to be about 90 degrees. So when you look at this patient, assuming this is natural head position, which it seems like, pretty close. I mean, maybe she's looking down a little bit, but where would you say these central incisors are? Yeah, they're less than 90 for sure, right? Yeah, so these are tipped back. So most of us, if not all of us, would agree that, to treat this patient, we do want to bring those incisors forward, all right? So that helps us with our crowding situation. All right, so what else do we see from a skeletal standpoint? Would you describe this patient as more dolichofacial, brachyfacial, mesofacial? Hypobrachy? All right, raise your hand if you agree hypobrachy. What's that? What? Okay, so maybe like me. So what are you seeing here what pieces of evidence are you looking at that's leading you to say that it's more brachyfacial? Like what are the actual landmarks that you can look at that help you make this determination? I mean, because it's not traced, right? If you have your Ceph, you just go off your numbers, right? I mean, and that's why we learn how to trace Cephs, right? Because but like you may trace every Ceph when you're in private practice, most orthodontists don't. So, but you need to know the landmarks that you're looking at to help determine, what type of a case this is. So I'm wondering, and I'm curious, are you saying brachy because before they mentioned there was a deep bite? And, that's fine if you are, because those two go hand in hand together often. But when we're looking at a Ceph, we have a much more complete picture about what we're seeing. So what are the landmarks on the Ceph that help us determine what type of facial height we have? Okay, you have the facial thirds, and okay, so you can kind of get a ballpark of, okay, well, how tall is it from here, down to here, down to here, okay? And so if you look at it from that standpoint, would you say brachy, would you say meso, or would you say dolicho? Okay, meso, all right, so what other landmarks do you have? So that one told us meso, all right, so what other landmarks do you have? Okay, you have the mandibular plane angle, all right, so let's look at that mandibular plane angle. From the mandibular plane angle, would you say that that's more meso, more brachy, or more dolicho? Now everybody's shy. What's that?
I probably leave meso.
Well, okay, I'm going to take meso off the table. So now you got to pick brachy or dolicho with the mandibular plane angle. So which one?
Probably dolicho, but she looks a little hyperdivergent. I think that's a shorter range.
I mean, would you guys agree? So when you see a brachy patient, what angle would you say that this oftentimes is? Yeah, 90 or sometimes less. 90 or less, okay? This, I would definitely classify as more dolicho tendency. I mean, you can see how obtuse that angle is, okay? So one of the pieces of information said meso. I made you guys pick one, and we had to pick dolicho on this one. What other piece of information do we have that would help us to determine the facial height on this image here? And your hint is that it kind of goes hand in hand with the mandibular plane angle, like they're kind of usually associated, although not. Yeah, the occlusal plane, right? Okay, so when you look at the occlusal plane, all right, what should the occlusal plane be ideally in degrees, all right, relative to your Selenasion line? What should this occlusal plane be, or relative to natural head posture? How many degrees should it be down normally or ideally? Little less, close, little more. About 7, right? All right, so about 7 degrees, right? So if 7 degrees is like ideal or normal, how many degrees would you say this is? Would you say it's more or less than 7? Okay, all right, so now we have a lot of pieces of information. So, we saw initially that this was a deep bite patient. So in our heads, we're going like brachyfacial, deep bite, brachyfacial, right? But don't do that, right? So look at the Ceph. The Ceph tells us like this is more of a dolichofacial pattern, all right? So being that it's a little bit more dolichofacial pattern, what does that tell you about how easy or not easy it's going to be to correct that deep bite whenever you do get into comprehensive treatment? Is it going to be easier or is it going to be harder? It's going to be easier, right? Dolichofacial patients, they tend to open up during treatment. So if you have a deep bite, dolichofacial skeletal pattern, that's a good combination, all right? That's not going to be super difficult to correct. All right, so anything else on the Ceph that you guys want to talk about or that you notice or that comes to mind? All right. We didn't mention this, but if anything, and again, you could measure your numbers to verify this. You could measure like A and B, or SNA, SNB. But would you say that the jaws are more retruded in general? Because we know she's class 1, right? So we're not so worried about how they connect with each other. But would you say they're more retruded or would you say they're more protruded? Retruded, right? All right, we can all see that, right? The maxilla, the mandible, You can see the A and B angle is going to, in a retruded jaw case, this is actually a really good question that might come up on your boards. In a retruded jaw case, all right? So class 1, all right, class 1, that doesn't change, right? Regardless where the jaws are within the face, class 1 doesn't change. You can move them forward, you can move them back, bimax protrusive, bimax retrusive, that doesn't change. How does your A and B angle change when you move the jaws forward in a protrusive case, right, bimaxillary protrusion, versus when they're back in a bimaxillary retrusion? So if they move back, like in this case, what does that do to your A and B? Nothing else changes. You're not changing the class 1. That stays the same. Both jaws move back. What does that do to your A and B? Does it decrease it or increase it? You got a 50% shot here. Increase. You almost got it right. That was really close. All right. So it decreases, but think about this, all right? Because your reference point is nasion here, right? So A and B. So nasion. So if you have two jaws that are related together, right? As these two go forward, this angle is going to get bigger and bigger and bigger. As they go back, you can see like, whoop, look, it's getting smaller, smaller because they're both angling toward the same way, okay? So when you have, and that's why when you have a bimaxillary protrusive case, what is the A and B? For you third-year residents that have looked at a lot of Cephs, like when you have a bimax protrusive case, is the A and B bigger or smaller than normal? It's bigger, right? Even though they're class 1, right? And that's why. It's just an anatomical function of where the reference points are and where those two jaws are within reference to it, okay? So we've got bimaxillary protrusion. We've got a dolichofacial pattern. All right, we didn't talk about airway question. We have some risks of impaction. We have some risks of possible root resorption. We have some risks of maybe needing to extract permanent teeth later. So what are you going to do in a case like this? All right, yeah, we got at least one other expandodontist, right? So the jaw size discrepancy, that's what I'm going to do. We're going to correct the jaw size discrepancy by expanding, okay? Now, we mentioned, and I can't really, anything else? All right, we're going to expand. Any other ideas? Okay, so are you talking after expansion or just, okay, yeah. So after expansion, retain with some type of a bite plate, right? Incorporate a bite plate into your retainer. I would 100% agree. That's exactly what we did. Okay, any other suggestions? Okay, yeah, upright the posteriors on the mandible. Now, why do you say that? Why do you say that that's necessary? Okay, it will give us more space for sure, all right? What else will it do? Now, I want you to think, like we said we're going to expand this case. So what does the occlusion look like after we've expanded? Right, they won't be coordinated anymore because there's not a posterior crossbite, right? The teeth have compensated. To your point, the lower teeth have rolled in, the upper teeth have tipped outward. So when we expand, the expander, and I mean, unless you're using a micro-implant supported expander, then it wouldn't do this. The teeth could roll back in. But you're probably not going to do that on a 9-year-old, or at least most 9-year-olds or 8-year-olds. All right? So when we expand, the teeth are going to go with the jaw. And when we take the expander off, we're either going to be in a buccal crossbite or we're going to be close to a buccal crossbite. So to your point, it would be a really good idea to upright the lower posterior teeth in some manner. Okay? So what options do we have to do that? All right, you can do a Schwartz, all right? So that's great, and I hate them because there's a lot of emergencies with them, and patients don't like them either. So, but that is it works, right? And there's still tons of orthodontists today that use a Schwartz, and there's a lot of benefits to it, right? You get total broadening of the entire lower arch, but that's definitely one way to do it, okay? How else could you do it? All right, you could do an E-arch, all right? So E-arches, for those of you who are not familiar with E-arch, basically it's like a lower lingual holding arch, but it's got a little spring in it. And as it, the spring basically lengthens the arch, so it kind of expands the lower arch. You don't have to necessarily activate it over and over again. You don't have to turn anything. You just kind of activate it once. The spring goes. They do come with a subset of problems, but I would argue that they're probably less than the problems that you would have with the Schwartz, and they are fixed, so the kid's not having to put it in and remove it. So an E-arch, that would be a good option. Any other options?
It's called a France appliance. It's kind of like a W-arch, but it's with a lower.
Okay. Frozat. We'll have to look that one up. I actually don't even know what that is. Okay, so that's probably a good one. All right, let's go simpler. All right. So what are simpler things we can do? Okay, you could do an activated lower lingual holding arch, right? You could put torque in the posterior teeth. You could also, if you had a loop, an adjustment loop, you could adjust that loop to procline the anteriors, right? So you could do an activated lower lingual holding arch. A lot of our pedo residents who have done phase 1 treatment have used an activated lower lingual holding arch. All right, so you do have to fit bands unless you're doing 3D printed bands. So that's a good option as well, all right? So what's another option? Let's go even simpler. Okay, you could. All right, so you could, depending on how long you're going to have your maxillary expander in there and how much expansion you need, and in this case, we don't need a ton of expansion. So maybe you just expand and remove it. Maybe they're not in a complete buccal crossbite. Maybe you keep the expander on just a little bit longer, okay? And then you're fine, right? Then maybe they hit like cusp to cusp, and over time, the lower teeth move out. For years in our practice, that's how we did it. I mean, really what made us stop doing that is when we started measuring the actual size of the jaws and realizing how much expansion we actually needed to coordinate them. We ended up having to do more expansion, in which case you end up with buccal crossbites more often. But yes, one option would be, depending on the amount of expansion, just take it off and let the lower teeth roll out over time. Although I will caution you, if you are only hitting on the cusps of the mandibular teeth, oftentimes you will see wear on those teeth. And that was something that I was seeing in practice when I joined. And you know, I didn't like that, right? Because it's like, yes, it works. You don't have to do anything, but at the sacrifice sometimes of wear on the teeth, and sometimes even class 6 caries, right? If you've forgotten what those are, I had too, but basically like, you know, caries on the very cusp of the teeth. I would see that sometimes. So I moved away from doing that for those reasons, but there's still like two options that are very simple that we haven't mentioned yet. So keep thinking.
Bite turbos.
All right, yes, bite turbos, right? So when the expander comes off, if they are in a relationship where you're worried about the damage to the teeth, you can add bite turbos or bite ramps to the lower posterior teeth. Essentially what you're going to do is you're going to go up there and you're going to build in a ramp, and you're going to move the tooth, basically you're going to move the ramp, and it's going to build it up like to the buccal here. So it'll be a big glob of band lock, or in my practice I use something called ortho acryl, which is a little bit softer than band lock. It's also clear so you can see through it, make sure there's no issues underneath what you've bonded to. And that's pretty simple, especially on young kids. We'll do that a lot on young kids because they typically can't tolerate much more than that. And so we'll just get the expander off, and if we're in a buccal crossbite, we'll add the bite ramps there, all right? There's one more thing that you can do actively during the expansion process to help upright at least the molars, the 6-year molars. Because in order to establish the bite, you don't necessarily have to have all of the posterior teeth in good occlusion. You at least need, you know, solid teeth in occlusion, which are the 6-year molars, right? So if your goal was to just get the 6-year molars into a better position and you didn't want to use any of the things we've already talked about, what other options would you have? Cross elastics, right? So you throw a button or a Kaplan or something on the lower lingual of the 6s, and you run a cross elastics to the outside of the expander, and you upright those teeth as you're doing the expansion, okay? In her case, if anything, if that opened the bite to some degree because they extruded, great. She's a little bit deep anyway, okay? So that's what we'll routinely do, is we'll just run some cross elastics because it's very simple. It's easy to do, and then when the expander comes off, the 6-year molars are in good buccal occlusion, all right? So this case, we did expand, all right? This was a year later. All right, so we can see here. Now, what happened? Like, so we've expanded, we've made room. You can see that there's room for the laterals now. You know, she does have pretty big front teeth. But what happened to the canines? All right. So are they telling us a different story now? Right. And again, so if you were monitoring this case, you would have seen this as well. So at some point, you probably, even if you weren't like an expandodontist at first, well, if you're monitoring this case a year later, you know, this is with expansion. So you can imagine what it would have been like without expansion. You know, you would see these changes. So the canines tend to be heading in which direction? Facial or palatal? Palatally, right? Because you're seeing that angulation increase. You're seeing them appear a little bit larger on the x-ray from a magnification standpoint. And the apex, or the tip of the canines are getting closer and closer to the roots of the lateral, correct? All right. So now when you look at the possibilities, root resorption, you know, like this has gone up, okay? And so now what are we going to do? Exactly, right? We're going to extract something. So yes, you look in the literature, you extract the C's, and you can get some great changes with that. The protocol that we use is we'll extract the D's first. And the reason we do that is because we want to get these out of the way. There is a little bit of space between the canine and the premolar here, but not a lot. So if we extract the D first, this does two things. So one, it gets this premolar out of the way. Two, it's a much more comfortable extraction for the patient than extracting canines, which, you know, it can be very... How many of you have extracted a primary canine with a full root? Yeah, how was that? Yeah, it's not a fun experience, right? So we'll have the D's extracted first, we'll get some space there, and then give them the roots of the C's a little bit more time. And often what we'll do is we'll place what we call exfoliating elastics on the canine at that point. And what that is it's basically a 1/8 inch, 1.8 ounce elastic. And it basically just chokes the tooth a little bit. So you put it on the neck of the tooth, and it starts to extract the tooth for you, helps it to get much more mobile. Oftentimes, you'll actually see the canines drop down even with full roots. I have had 1 or 2 patients where the rubber band literally extracted the tooth. But most of the time, it makes them loose enough that in 6 months, the dentist can easily take them out, and it's a much more comfortable experience for the patient. All right?
When you do that, what's your follow-up with the patient? Like, so you put the elastics on, and then you just say...
I see him 6 months. Yeah. And I always tell them, a couple things. So I do a couple things. So one, I will send a letter to the dentist, and it says, hey, we put a rubber band on this tooth, and if you ever feel like you need to extract it, go ahead. Like, we give them the green light. And we also tell them that because, like, for a while I didn't, and then we get calls from dentists being like, whoa, what's this rubber band? So you want to communicate that, right? So the letter will go out, we'll tell them what tooth we put it on, and it'll also say, hey, like, if you feel like taking it out at one of your appointments, feel free. Like, by all means, you don't need permission, like, you have it. So it's like an RX that way. 1/8 inch, 1.8 ounce. Yeah, very small. They're hard to get on. Yeah, like, elf fingers would work well for that. When I first started placing them, like, I would use like a mathau and floss sometimes. Eventually, you get good at it, and I almost never use a mathau, just my fingers to get them on now. But there is a learning curve there. And then the other thing I always tell the patient is, if it comes off, don't try to put it back on. All right, because that's like my biggest fear, that it's going to come off, and then they're going to try to put it back on, and they're going to put it on the wrong tooth, and they're like going to put it on their central or something, and that would be a bad day. So those are the 2 things that I always tell the patient when those go on. Okay, so now we fast forward another couple years. You can see that those teeth are coming in. All right, so what new problems do you see? Okay, who would agree that there is potential ankylosis of number T? Okay, definitive ankylosis, right? Well, if it's potential, now I love the way you're thinking. I'm just like, like giving you a hard time about your word choice, right? So if it's potential, that means that there could be something else explaining why that is the way that it is. Now, if you can come up with something else that explains that, then I guess, like, technically you could be right, because it could be like, they had a bite ramp on their tooth for a year and they just now removed it and took that x-ray. So I guess technically it is potential. So yes, you're right. But pretty darn sure, right, at this point, that tooth is ankylosed, right? You have a history. You have where it was acting normally, both sides. You can see here, both sides acting normally, occlusal plane normal on both sides. And then we fast forward a couple years, and now we have acting normal on the left side, occlusal plane still the same, acting not normal on the right side, okay? So what else has changed between these 2 images as it relates to that ankylosed tooth that actually broadened your options of how you can deal with this? Because last week we talked about decoronation as being a good option to get the bone levels correct and keep the option open for an implant, right? But what changed between last image and this image?
When we have the 7s and 8s forming, we could just take it out and protract the 6 forward.
Exactly, right? So on our first image, we didn't see the 8s forming, right? I mean, we would hope that they would come in, but we didn't know. Now you can see we have a normal 7, we have an 8 forming behind that. So if I were to treat this patient in my office, and this was a very early case, so like a lot of these cases that we go through are cases that were earlier on. So like I didn't treatment plan this case. I treated this case with Dr. Hamilton. At the time, we decided to extract that tooth and just see what happened. Just let him go for a little while and see how much space closed. Ultimately, we ended up reopening the space for an implant. If I were to retreat this case today, absolutely, I would extract it, place a tab, mesialize that side, and use the 8 long term. That's like routine in our office now. Okay, so this is what the teeth look like after they were extracted. Okay, so you can see here we have, the space closed up quite significantly. The lower midline you can see did shift over slightly to her right-hand side, so we had some space closed, from both directions, but not too much in the anterior. Most of it was in the posterior. And this is where she presented for phase 2. All right, look at the x-ray here. You can see the tipping of the roots. And again, at the time, the decision was made to, because the roots were so tipped, okay, well, let's just upright those, kind of push the lower midline on. And again, like if I were to treat this patient again today, then that would not be my treatment of choice. But check out, like I say, we expanded. We got the upper jaw wider. When the upper jaw widens, what other 2 directions does it go? Forward and down, right? So check out the Ceph from from a few years later, right? So looking at where the jaws are, I mean, granted, the jaws are supposed to grow forward. That's normal, right? So I'm not saying that like there was anything magical that happened, But look at the difference, I mean, from all the standpoints. I mean, the occlusal plane even, right? The occlusal plane is less dolicho looking, right? We're a lot closer to 7 degrees now than we were when we started. The mandibular plane angle is a little bit more acute. I mean, I'd still say if I had to pick brachior dolicho, I'd still pick dolicho, but it's a lot better than where it was. And again, this is one of the reasons I like to get the jaws as ideal as possible when the patient is young and it's easy to move the jaws. Typically, when you move the upper jaw in the right position, the lower jaw tends to follow a little bit better or more predictably. And if we have time later, we'll go through some cases that demonstrate that. Okay, so this was her phase 2. She was in treatment for, it looks like about 19 months, which hopefully today it would be less than that. Not a perfect finish. You can see we still need some settling on the right side. You can see more gingival display. Honestly, there, with that, well, actually, let me just ask you, when you look at the smile and you're being really critical, what stands out? Yeah, there's a cant. Why is there a cant?
Probably just because there's less, there's not that tooth, so it's super erupted a little bit. Those premolars
Yeah,
are a little bit lower.
So how well did we do with the management of the ankylosed tooth? Like, we probably could have done better, right? Yeah, because had we identified that a little bit earlier, maybe those teeth wouldn't have moved down. And then orthodontically, we probably should have spent a little bit more time getting those teeth up where they needed to be. Now, at the end of the day, she's a happy patient. You can see we have, room for the implants. Still has the wisdom tooth that's going to have to be addressed later. So is it a perfect finish? No, it's not a perfect finish. But at the time, the way that we treated, we felt pretty good about it. I look back at this case now and I'm thinking like if I saw this case now, I would not be very excited about it. You know what I mean? I'd be like, dang, like my roots were not that great. With the lateral, the cant's still there. Like I didn't get that molar back to class 1. Like there's a lot that I would, improve now. But we practice a lot differently now. We have all digital setups. We have comb beams that we can look at to identify root position. So there's a lot that we can do now that we didn't do then. But at the end of the day, a happy patient. Okay, questions? Yes.
When would you place the pads and easilize that tooth?
So my protocol for doing that is I get to a 20 stainless steel wire, and when I get to that 20 stainless steel wire, that's when I'll place the TAD. So going back to, I'll just show you on this one because it doesn't really matter. But
Phase 2?
yeah, in phase 2.
Okay.
Yeah. Always in phase 2 because it's going to require a lot of work. So I would have done the exact, like if I could go back and treat this case again, as soon as I identified the ankylosed tooth, which should have been a lot earlier than we did, I would have extracted it, right? So that would have been gone earlier, okay? And then they would have presented with most of that space closed, so I had to put them in brackets and started leveling, get up to a 20 stainless steel wire. As soon as we're in a 20 stainless steel wire, we would place a TAD depending on where the roots are, either between the 3 and the 4 here or distal of the 4. From that TAD, there would be an arm that runs from the TAD up to the wire to stabilize it, and then we would start dragging that right posterior quadrant forward. And that's typically how we do it. And then once those teeth are all the way forward and the roots are upright, then we would finish the case. All right, any questions on that?
When you retain that space for the implant, do you ever do anything fixed? Do you like to do a poly?
So typically, I don't usually use things that are fixed, like in general. Yeah, so typically it's an Essex or a Holly, but I typically use Essex for most retention. Yeah, they just wear it at night. Yep. So with anterior teeth, you're going to have a daytime and a nighttime. Like if you're holding space for laterals, you'll have like one with the tooth in it for the daytime and then one that actually dips down to hold the space at nighttime. Although for maxillary laterals, I do always recommend that the patient look into getting like a one-wing Maryland bridge because a lot of times you will see divergence of those roots or convergence of the roots and it can create a problem, later on. So great question. Any other questions?
When you protract the molar, do you do anything special to get better occlusion within the premolars?
You're going to finish class 3 molar when you do that. Yeah. So is it going to be perfect? No. I mean, the occlusion is never like socked in like it would be if it were class 1 or class 2. But long term, as long as you have a good group function, you won't, you typically won't see problems with that, right? So I'll always just explain to the patient, like if you look in a textbook, like your molars are going to look different, but or you could have an implant, for forever. And what are the consequences of having an implant for 80 years or 70 years or however long you might live? Like we don't know, right? I mean, implants haven't even been around that long, so there's a lot of unknowns with that as well. I mean, who knows? One day we might be able to just grow teeth, right? Just like, oh yeah, just plop that in there, and like you grow babies, you can grow teeth. I don't know, like maybe you can do it, but so we all like my thoughts are like I want to go with what's predictable. I know that if the tooth is in a class 3 relationship and a good group function, then I can predictably think that they're going to last for a long, long time, more so than I can rely on an implant. Okay. Say that again. Uh-huh. Yeah. Yeah, it's a lot more complicated at 35, and here's why. So one, I mean, like growth is such a huge benefit to you as a practitioner, because when they're growing, bone and gums are just automatically happening, right? I mean, it's just like they regenerate quickly. That's why you don't see like black triangles in kids, almost never, right? Adults are totally different. So, you know, the other thing that's different in a 35-year-old compared to like a 10-year-old is that the bone is oftentimes more atrophic. So you'll see a ridge that's very, very thin. And yes, can you move the tooth into that ridge? Yes, you can, but oftentimes that'll be accompanied with recession on either the buccal or the lingual. And so it's not an ideal situation. So I have moved teeth in adults with missing premolars like that, and most of the cases where I have done that, I have regretted doing that. And so I don't typically do that. So it's got to be a pretty ideal setup, like, you know, great buccal width, like healthy patient, everything looks like ideal for me to even attempt that. If there's like ridge, already existing recession, vertical defect on the anterior, like I'm not going to do it. I'm just going to hold the space for the implant. Yeah. And that's, again, just learned by experience, you know, tried it a couple times. And then it also takes forever to drag it through the bone. You're doing microosteal perforations to try and, you know, speed it up. I mean, these cases took 2.5, 3 years, and the result just, and I can think of one of them that I didn't even get there. Like one of the only cases that, like, I finished because I couldn't finish. Like most cases, like, you know, all cases go south, right? But usually with TADs, I mean, with all the stuff that we have at our disposal, you can get out of the case pretty good. Yeah, it might take a little while longer. But I can think of one adult right now where I couldn't get it finished. I was, you know, mops, TADs, like everything. I could not get the space closed. We started having more recession on the mesiobuccal cusp. I'm like, hey, you know, I can push it back, you know, to where it was, or, you know, you can have spaces and you can clean them and be in a group function on that side, and, you know, they were done. But again, like, you know, lessons learned, yeah. So to answer your question, no, I try not to close spaces on adults unless it's got to be really, really, really ideal. And the younger the adult, like, you know, maybe 20 or 22, 25, you know, okay, maybe a little bit more likely. But yeah, you get a little bit older and the risks just go way up. So any other questions? Yes?
On that case, you mentioned just the slight cant. Do you prefer just like rebond? That's the right side?
Yeah, let's go back. So because you make a good point, and yeah, let's look at this real quick. There we go. Yeah, so you have to make the determination on is the cant, where am I at? There we go. Is the cant due to just those teeth in that section, or is the cant an entire maxillary cant? And there's a lot that goes into that, right? So one of the things that goes into that is, do they smile symmetrically, right? So if they're smiling symmetrically, then you can really trust what you're seeing as far as the gingival display on one side versus the other. So looking at her smile, I would say her smile is pretty symmetrical. I don't see it certainly doesn't look to me like the right side is hyper elevated compared to the left side. I think looking at the eyes, and yes, we could correct this photo a little bit. We could probably line up her eyes a little bit. I think the smile is symmetrical. So that tells me that, you know, it looks like even at the level of the canine, it's further down on the right side than on the left side. So if I wanted to correct this, I'd be looking at placing a TAD on that right side and intruding that right side up so that we could get that completely level, right? And then extruding the teeth on the bottom to match. So that's how I would do it today. Yeah, but if you only did the premolars, that would definitely help a little bit. Yeah, for sure that would help a little bit. If they didn't want to go through the TAD intrusion, you could even kind of cheat it a little bit. You could consider like having them get crown lengthening, right? So that it's actually not very noticeable. Like if you crown lengthen one side compared to the other, like even though those teeth are a little bit longer, it's not super noticeable. Like you'll notice the cant and the asymmetric gingiva more than you'll notice like one side of the teeth being longer than the other side of the teeth. Yeah. Any other questions?
Protocol really quick for protracting the molar. You said TAD, temporary anchorage, or then do you just PC it, or do you use Metec foil?
Yeah, let me just show you. Yeah. All right. I'm pretty sure at least. Let me make sure I have a case here.
One that I'm doing right now, where it's just we're doing direct with the PC, so I can power all of this.
Okay. I'm trying to remember which Oh, you know what? I'm offline right now. Shoot. Okay. Well, I'll bring a case. I'll bring a case next month, and we'll go through it together. Yeah. So I'll write that down. I'll bring a couple cases. Yeah. So you can see the mechanics for the molar protraction. So yeah, we'll do it like, unilaterally, bilaterally. Like, I've done it where it's like 3, like, because they had 1 premolar and then or 2 on one side and then 1 everywhere else. So like, I don't really care. Like, we'll just like, if they have an 8, then I'll close the space. And if they don't have an 8, then I'll at least give them the option. They may want to stay with first molar occlusion. Yeah.
How long are you quoting timeline for your visualizing the 6?
Yeah, 19 to 21 months in a kid. Yeah. It doesn't take, like, when your mechanics are set up right, it doesn't take like a tremendously a long amount of time. In an adult, like if I was going to attempt it, like in a 20-year-old or something, I would tell them like 2 to 2.5 years. Yeah. So, but yeah, in a kid, 19 to 21 months. And in my mind, I'm thinking like I'm probably going to finish before 19 months. And again, I'll bring some cases next time to show you. Okay. Other questions?
Is the next date been set yet?
I believe it has. The next date will be, let's see. I'm not here in March, so it'll be April 19th. Yeah, it'll be April 19th. So we will see you all then. I just barely started recording it. So that was a suggestion of one of the residents, and so we'll see how it goes. I posted one. I kind of screwed it up last week because like when I played a video, it like tweaked out the audio, so I'm hoping that doesn't happen with this one. But we did have video, but we didn't get to that one yet. So next time we're going to talk, unless they have cases. So if they have cases, we'll start at 7, and we'll go through the cases first, and then we'll do lecture afterwards. But next time is going to be functional appliances, and there's going to be some stuff I'm almost sure that you've probably never seen. At least I'd never seen it. So that'll be fun. Awesome. You're welcome. Yep.